Flitner. Hallinan. Ottman. Martinez. Stivar. Wharf.
Here.
Madam Chairwoman Wilson.
Here,
8 present, 1 excused, Madam Chair.
very good. And we're so glad to have Representative Clifford back and not in a little rectangle. We're glad you feel better. Okay, so committee, this morning, we're going to hear House Bill 83, Healthcare Cost Control. Representative Stith is and here he is. And he has got another committee at 8:30. So we will let him launch directly. Come right up.
Good morning,
Good morning.
Madam Chairman, members of the committee. Thank you so much. So House Bill 83, so what's the problem that it's trying to solve? And the problem that it's trying to solve is the fact that if you do not have health insurance, when you go to a hospital, for example, then the price that shows up on your bill tends to be higher than it would be if you had private health insurance, if you were covered by Medicare or if you were covered by Medicaid. So they have 2 potential proposed amendments to this bill that I just wanted to go over quickly. As drafted, the original bill draft is very expansive, would apply to all healthcare service providers. And the first proposed amendment would be to limit it to hospitals. I think that makes the bill somewhat more manageable. The second proposed amendment that you may want to consider would, instead of keying the price that the uninsured get charged, instead of keying that to the lowest cost paid by a private health insurer, which could be difficult to administer, the suggestion would be to key it to a percentage of the Medicare rate, which would be easier to administer. And as a ballpark, I was suggesting that the prices charged to an uninsured patient would be no more than 200% of the Medicare rate. And why 200% instead of some other percent? Well, in part, I'm not a healthcare policy expert. I did run across at least one study by the RAND Corporation that tended to indicate that across the country, including Wyoming, that for inpatient hospital services, the Medicare rate is about half of what private healthcare insurance pays. So 200% of the Medicare rate would be about what the typical private healthcare insurance rate is. So with that context, so in my heart, I'm a free market person. I mean, I don't like price controls, and this bill is all about price controls, right? But the market for healthcare services is so broken that I believe some regulation could be appropriate. So who are the people who are uninsured? Who are these people? Are they wealthy people or are they poor people? They tend to be the working poor. What I see in my office, people come into my office, I see a family with children coming to my office. They're thinking about filing bankruptcy. And typically I already know who their creditors are. It's going to be at the local hospital. It's going to be healthcare bills. Typically that's what's driving, about half the time, that's what's driving someone to file bankruptcy. And one of the issues for these people is that they're living paycheck to paycheck, but then they have some medical event happen to them. And then they go to the ER, and what they get charged at the ER is a lot more than what they would have been charged had they been covered by private healthcare insurance. So, and I apologize if this example is too simplistic, but imagine that a hospital, instead of providing healthcare, let's imagine that it ran a grocery store. And you have 4 customers who walk into the grocery store and they go to the meat department, and you have a 1-pound ribeye steak, and they each pick up one, and the label says they each cost $20. But when they get to the register, the first customer is a Medicaid patient. So it says $20 on the package, but what actually gets paid for that steak is $5, say. The next customer with their steak in their hand that says $20 on the sticker price, what they pay is about $8. And the next patient has Blue Cross Blue Shield, and that customer pays $15 for the steak. And the last person in line has no insurance at all, and that person has to pay the full rack rate of $20. So the question is, what's the social good here that we get out of price discriminating against the uninsured? And I would submit to you that it's not only unfair to the uninsured person, but it's not really helping the bottom line to the hospitals all that much. I mean, private uninsured paying patients account for typically less than 5% of their total gross revenue. And one of the reasons for that is because the default rate's really high. That is, the person who's buying the steak for $20 will tell the cashier, I'll pay you later, and then often doesn't pay. So, because I don't think there's any social virtue into price discriminating against the poor, and this price discrimination, the effect of it is to drive people into bankruptcy who otherwise might not file bankruptcy. That if we said, just as a matter of fairness, that the hospitals can charge, but what they can charge won't be more than what they're charging someone with insurance, that's the idea, then the effect of that would be that more people would actually be able to pay their bill instead of filing for bankruptcy. So the net effect on the bottom line, it's hard to know, frankly, exactly what the effect would be financially, but it's well possible that the hospitals wouldn't lose any money on this. Yes, they would be charging a lower rate. So for a surgery, instead of charging the $12,000 for the gallbladder surgery to the uninsured patient, they might be charging the $8,000 instead, but they're much more likely to get paid, or somewhat more likely to get paid. So the default rate should be lower. So having said that, this is a policy issue. This House Bill 83, it may not see the light of day in this form. It may not pass, but this issue is not going away because there's no principled reason to say that price discriminating against the poor, against the uninsured, is a good idea. It's just not a good idea, and it's unnecessary. So with that, I stand for questions.
Questions for Representative Stith? Representative Stivar.
Thank you, Madam Chairman. Representative, I agree with you. We shouldn't be discriminating against the poor, but I've got ABC insurance and I have deductible, so my insurance company pays, but my deductible that I have to pay is more than what the Medicaid rate is. So where is the fairness in that?
Representative Stith.
Madam Chairman, Representative Stivar. So yes, up to your deductible, let's imagine that you get an MRI at the hospital. And the price that the sticker price, let's say, is $1,600 for that MRI. And let's imagine you have Blue Cross Blue Shield with a $2,000 deductible. What the hospital has done is it has agreed, even though its charge master or sticker price is $1,600, it has agreed with Blue Cross that because you have Blue Cross, you will not be charged $1,600. You will be charged $1,250. And then you have to pay that, right? Especially after deductible, you're paying it all. The uninsured patient, by contrast, gets stuck with $1,600. And then when they don't pay, they get turned over to collection and they get sued in small claims court.
Representative Stivar, follow up.
Thank you, Madam Chairman. Okay, you brought MRI up. My wife has a meningioma and she goes in and gets an MRI every once in a while. In fact, it's coming up now. A couple of years ago, we were in there at a place to get her MRI. Lady come in front of us, had no insurance. Her MRI, they said, we'll do it for $475. But my co-payment was higher than that. So this is where I don't understand this.
Representative Stith.
Madam Chairman.
Wading into a morass.
Representative Stivar, that's an interesting anecdotal example. If it is in fact the case that you have hospitals who are currently charging the uninsured less than what they're charging for the insured, that's very interesting. Certainly they're free to do that, and that would be a surprise. I don't think that's not the typical case, I don't think, but I would say that this bill would not change that. That is, this bill says only that they would not be allowed to charge, as presently drafted, what Blue Cross Blue Shield is paying. And under my suggestion, 200% of the Medicare rate, which would roughly come out to be the same thing. So if the hospital chose to give the uninsured a break, that's their choice, I guess. But I don't think this bill would affect that situation. I don't know if does that answer the question?
Thank you, Chairman.
Representative Connolly.
Thank you, Madam Chair. And actually, it's somewhat of a follow-up to Representative Stivar's example. But first, let me tell you, Representative Stiff, I like the idea behind this. I do. I'm having a hard time thinking about how it would get administered. And so you gave the example of a price and a negotiated with Blue Cross Blue Shield. I just had knee surgery. I'm getting bills all over the place, and I'm seeing that negotiated price with Great West. I have Great West. I would assume that there are different negotiated prices between a provider and the different health insurance companies. So how does that play out in your bill when there is not even a standard price when it's negotiated?
Representative Stiff.
Madam Chairman, Representative Connolly, you are exactly right. There are the discounts that a hospital extends or that is negotiated or agreed to between the parties is different depending upon the insurance company. And it's because of that problem and frankly, the difficulty of administering this bill as originally drafted that my suggestion is to replace the original language in this bill with a formula that would key the maximum price that could be charged to the uninsured as a percentage of the Medicare reimbursement rate. That would solve the problem of having to figure out what insurance companies you're dealing with. And it would also perhaps not distort the negotiations between the hospital and the insurance companies. And I say negotiations, I don't want to make it sound like this is necessarily an arm's length negotiation between, say, my local hospital in Rock Springs and Blue Cross Blue Shield. I assume in that context, Blue Cross Blue Shield just sends them a notice and says, here's what we're going to pay, and they just take it. But I don't know. I'm not privy to those things. I think across the country, the amount of discount depends upon the relative bargaining strength between the hospital, for example, and the insurance company. So if it's a very desirable hospital, like the Mayo Clinic or something, then the insurance companies get pushed into paying a higher percentage of the so-called rack rate. But does that answer your question?
And before I'll call on you to follow up, I just wanted to say, I do see Representative Romero Martinez is on Zoom there with us. So Representative Romero Martinez, if you have a question and I'm not looking, feel free to kind of flail wildly so that I can, and other people may point it out to me in case I don't see him raising his hand there. Okay, Representative Connolly, go ahead, follow up.
Thank you, Madam Chair. And that, just to be clear, the amendment that you're talking about is what we have from Representative Hallinan. Is that true?
Right.
Okay. And then my last question, Representative Stiff, does any other state do this?
Representative Stiff.
Madam Chairman, not to my knowledge, Representative Connolly. So in fairness, and I think we have to be fair to the hospitals because they're often themselves economically in a difficult circumstance, especially if it's a public hospital who has to accept emergency room patients, for example. The uninsured present particular challenges to them because they have to treat them. They provide expensive services, and often it happens the hospital doesn't get paid at all. And so the default rate by the uninsured is very high. They're not paying their bills, right? And I think I understand that. Having said that, I don't think it's good public policy to say, well, because I think you might default, I'm going to charge you a higher price, right? That just tends to make the problem worse. So,
Representative Ottman.
Thank you, Madam Chair. Representative Stitt, I realize that healthcare isn't your full-time position, but I was wondering if a person goes into an emergency room and they do not have insurance, it has a person that I know, a constituent, they went in and they were told the price that it would be because they asked. And they said, well, that that's too high and I do not have insurance. Do you have a cash rate? And they were presented with a file folder full of paperwork and said, you can fill out this paperwork for indigent. How does that fit in there? Thank you.
Representative Stith.
Madam Chairman, Representative Ottman, my understanding, I do have some familiarity with how my local hospital works their own program like that. They certainly do have programs where if you're indigent, you can apply to get a discount or to get your bill written off completely. But not surprisingly, they will say, hey, well, if you have equity in your house, or if you have a retirement account, if you've got $30,000 in your 401k retirement account, then you're not going to be eligible for this, because we want to help people who are truly just indigent. We're not going to help someone who does have assets that they could theoretically liquidate to pay for this service. So I want to be careful not to paint hospitals, for example, as the villain in this story, because again, they're stuck in difficult circumstances, and they do have programs for their own self-interest. They want to try to squeeze the turnip as much as they can to get as much blood as they can, right? So it's in their interest to give someone a discount, right, on a negotiated basis. However, the baseline policy or practice, I should say, of charging an extra 30% to the uninsured because they're uninsured just seems unfair to me. So fairness is what sort of animates this bill.
More questions for Representative Stith? Representative Splittner.
Thank you, Madam Chairman. And Representative Stith, how does this work in the legal profession? Because I know lawyers do pro bono work, correct? But if someone cannot pay, do other people who do have the ability to pay, do they make up that difference? I was just wondering, if this same principle could be applied with regard to the legal profession.
Representative Stith.
Madam Chairman, Representative Flintner, I would hope that there would be some insurance company who would pay legal bills to my clients. I would love that. But unlike the healthcare field, my clients, when they're paying me out of their own pocket.
Mm-hmm.
They're paying me every dime out of their own pocket. But we're at healthcare, very different market for a couple of reasons. One is that you do have this insurance overlay, right? And part of the problem with this insurance is that from the vantage point of the insured and the provider, it's other people's money. So if there were an insurance scheme where my rack rate were X, and the insurance company would pay 85% of that for most of my clients, I would love that, but I don't get that, right? I mean, all of my clients are uninsured. Let me put it that way. But to be fair, what I typically do when a client comes to me with a problem is I try to find out what they can afford. And if they can, if some people might have a very complex legal problem, but they've only got $800, right? And so I'll say, okay, well, here's what I am willing to do for $800. Okay.
So let's follow up a little bit though on that, Representative Stith. You referred earlier to about public ERs that can't turn people away. Actually, the EMTALA Act from, I think it was 1985, applies to all hospitals. If a patient comes in, the patient needs to be seen and stabilized. They can't send them away. And so unlike the legal profession, you can turn people away, or you can say, I can only provide you $800 worth of service. A person doesn't come in saying, I moved here from the Middle East. I have 3 wives. I want to divorce them all. And I have 27 castles. And this will, and by the way, you have to do it for free. I mean, the hospital doesn't have that liberty. I'm just throwing that in there.
And Madam Chairman, that's exactly right. The healthcare services market is different than most other services. It really is in all sorts of ways. That is, as a patient, if you are the patient and you're in an emergency, you don't really have time to go shop around for the best price. You just don't, nor are you price sensitive even. You're not price sensitive when you need medical care for something that's an emergency, at least.
Okay, folks, I'm trying to, I don't see any more questions at the moment. Representative Stith, so I have 8:24 on my clock up here. I don't know if you want to run right across the hall or if you want to sit through a few minutes of next testimony and hear what it is. Either way, we
Madam
appreciate
Chairman, I
your-
so thank you for your time.
Oh, Representative Romero Martinez.
I just wanted to make a couple of comments. Can you guys hear me in the room there?
Yeah, are they questions specifically are they questions that Representative Stith can answer? I mean, because otherwise we might dismiss him if he doesn't have to answer them.
I guess my question would be, well, I'm going to say no questions.
Okay,
So maybe-
we'll hear your comment after, but I just wanted to
Yes,
make sure that we
Absolutely.
organize
Thank you,
for
Madam Chair.
this time. Okay, so feel
Madam
free to
Chairman?
be dismissed if you like, or you can kind of lurk in the back for a few minutes and look out the window, or if you go down the hall and see you're not up yet and want to come back, that's okay too.
Thank you so much for your time. I really appreciate it. Thank you.
Okay. Okay, do we have any public comment? Come up, whoever you are. I don't mean whoever you are, I know who you are, but. Although many of us know you, if you'll introduce yourselves for the record. Welcome to the new and improved plastic wrapped labor committee.
Madam Chairman, Eric Boley, President of the Wyoming Hospital Association.
Madam Chairman, Josh Hannis, also with the Wyoming Hospital Association.
Welcome.
Thank you. And committee, we'll be spending a lot of time together over the next couple of years, I have a feeling. Every session, there's one of these bills that comes up that causes me some concern. This is one of those. I spent a sleepless night Sunday preparing for testimony, and then we got to hear that fantastic bill on Monday, which I was very moved and touched by. And then I spent another sleepless night last night thinking about this particular bill. And I go back to my 20 years of experience as a hospital CEO. I was at South Lincoln Medical Center in Kemmer for 20 years, both as a business office manager, then as a CFO, and then as the CEO. And so understanding the revenue cycle and understanding billing practices is second nature to me. I'll also let you know, I think a lot of my hospitals are online and are anxious to help add some testimony here. But I think a couple of things that I want to get out of the way quickly. There was some misinformation and misrepresentation already. There is no discrimination. And I think that that's an inflammatory term. We do not discriminate at all. We take care of every patient that walks through the door. We have to, and whether they have the ability to pay or not. If we accept Medicare or Medicaid, which all of our hospitals, our acute care hospitals do, we take care of you if you walk through the door. We do not discriminate in what we charge patients. Under Medicare, CMS rules, which CMS is the federal Medicare agency, we have to charge everyone the exact same amount. It's against the law for us not to charge the same for the same procedures to every patient. Now, what is collected is very different. And I think that's really what the crux of the matter is here. Those of us that have insurance, we buy insurance so that we don't have to pay the full bill. And on top of that, we pay premiums so that the insurance companies can negotiate on our behalf and pay our bills. We do have out-of-pocket maximums. We do have deductibles that have to be collected. And under the new insurance market, some of those are very large amounts of money. $10,000 out-of-pocket maximums, $2,500 deductibles, where years ago we used to see $250 deductibles and $1,000 out of pocket. It was a different world several years ago. But that's one of the things that insurance provides, and that's why we buy insurance. I will tell you, as a young married man, my wife and I wanted to start our family, and we chose not to do that until we could afford to do it. That was a decision that we made. And I understand the emergency room is a totally different animal. If someone needs immediate care, we want them to have that care. But what I'm trying to tell you is, in my early life, I took responsibility for choices that I made. When it was time, I became well-informed, and I went in and I met with my hospital and figured out what I was going to have to pay. I talked to them about my financial situation. And what I would submit to you is that is actively happening in every one of our hospitals in the state. We provide $120 million worth of uncompensated care annually. And that is our cost It's not what is charged, it is the cost of delivering that care. And a lot of times I think we lose sight of that. Our hospitals are on the heels of one of the toughest years that any of us could ever imagine, are doing the very best they can to serve their communities. And we have heroes working in those communities that have done a lot. So let's talk a little bit about collections, I think. There are very robust collection procedures in all of our hospitals, and there are best practices that are followed. And this has been one of those areas of concern for a lot of years. There's been look at it from the federal side of things, the American Hospital Association, which all of our members belong to. We have worked diligently to try and put really good practices in place. And I would let you know that if you are an uninsured patient and you go in and you meet with the revenue cycle people, with the collections people, with the billers in the hospitals, they're going to come up with a solution for you. And so even if you are charged a certain amount of money, if you go in and talk to them based on your income level and other things, there's a sliding fee schedule based off of federal poverty guidelines that's used to sometimes write off the entire bill. If you have income, then we help with cash discounts. We also provide interest-free payment plans that extend out to 4 years. You know, we use the supermarket as an example. If you go into the supermarket, you're going to pay, and it's not a negotiated rate. In hospitals, you can negotiate that, and it's not really even a good comparison. A hospital and a supermarket buying a T-bone steak is a very different animal altogether. But what I would let you know is that we've worked diligently to make sure that we have collection practices in place that are fair to the patients. The other thing I'll let you know is it is a long process from when a patient is seen and treated in our hospital to when and if they are ever turned over to an actual collection agency. Once it gets to the collection agency, it's kind of out of our control to a certain degree. But up until that point, it's usually 45 to 60 days before you receive your first pre-collect letter, just saying, hey, you got an outstanding balance. We'd like you to make arrangements to get that paid. Usually we pay $3 to $5 per letter that is sent out. Then you'll usually get a second pre-collect letter. Then you'll get a notice letting you know that you're going to be turned over to collections. Then normally you get another letter saying it's time we're turning over to collections. And somewhere between 90 and 120 days, the account may be turned over to collections. The collection agency, the one that we work closely with, usually sends out another letter, says, hey, you've been turned over to collections. If we can get this rectified or taken care of, no action will be taken. And then the process starts. It's an expensive and timely process that we really want to avoid at all costs. And it's usually the last thing that we would do. We'd rather set you up on a payment plan, interest-free, and collect over time. There is also the time value of money. If we can get a cash payment at a discounted rate based on your income and get you paid in full, a lot of times it saves us money as opposed to chasing after these collections and hurting people, which is not really what we want to do. Our mission is to take care of people, to heal people, and to help them in their lives. As far as the working poor is concerned, again, I submit to you that we have things in place to help those people. As you're all aware, and I hope this doesn't turn the testimony, but we're in favor of Medicaid expansion to help the working poor. We think that at least there would be in coverage for them and there would be payment for those services. But because there isn't, we use the collection guidelines that we receive through the federal government, and we use the federal poverty guidelines to determine whether or not we write off 40, 50, 60, 70, 80, 90, or 100% of the bill. Anything you want to say? Is that all right, Madam Chairman?
Yeah, Mr. Hennis.
Madam Chairman, members of the committee, just a few additional comments. To Eric's point, and really to Representative Stivar's point earlier in the story that he shared, is that sliding fee scales based on your income are incredibly generous. So if you were to go into emergency room, anybody with insurance, I think we've all had an experience where those bills are quite high. Based on your income at several hospitals, your total charge for that could be somewhere in the neighborhood of $75. a lot of sliding fee scales will go up to 400% of poverty. And just because you have insurance doesn't mean you can't be on that scale. You could be insured and based on your income with what's left over, still fit on the slide in certain hospitals. And we can provide examples of those if it's of interest to the committee, but I did want to point out an example of what that might look like in terms of a slide. And then just the last thing I'd want to offer is that I think the Hospital Association over the years has worked closely with this body and been willing to be proactive in solutions. And certainly this group and all of your colleagues are interested in healthcare in Wyoming. It's an important issue. And we're happy to help convene stakeholder groups to have those conversations with some rigor and discipline and come up with real solutions. Currently, the governor has a task force looking at healthcare. We sit on that committee, happy to bring those ideas to that group and vet them through there if that's your preference. But we're here to have these conversations and work on problems as you've identified. So I would stand for questions.
Representative Hallinan.
Thank you, Madam Chairman. Mr. Bowley, wouldn't the twice Medicare rate or twice the Medicaid rate, wouldn't that be enough to pay for most of the bills that you have?
Mr. Bowley.
Madam Chairman, Representative Allen, it's a great question, and I didn't touch on the Medicare conversation itself. So we would let you know that Medicare does not cover our costs. Never has. And you were in private practice, you know that Medicare rates aren't sustainable. And if we want to start talking about Medicare for all, we all know that that would bankrupt our hospitals in a matter of a year, maybe 2 years. A percentage of Medicare, I don't know if 200% of Medicare is right or wrong. And that's the thing is we're throwing numbers out here without actually doing any research and seeing what that looks like. I actually think the way the system works right now makes more sense. I think you're creating an administrative burden. You're changing things around, and our hospitals are already heavily regulated. I will also let you know that under an executive order from President Trump, all of our most common CPT codes, which are our charge codes, are now posted with the negotiated rates to all of our websites. So if a patient wants to be proactive and plan and look at what has been negotiated and price shop, that's available to them. We've also had on our website for 9 years before I took up this position, but was still in Kemmer. I was on the board of the WHA. We enacted a thing called Price Point. You can go out and you can shop every hospital in the state, their prices. That does not have the negotiated rate, but under the new executive order, the negotiated rates are also readily available. But I think when we start to get into tying anything to a federal program, whether it's Medicaid or Medicare, I'm not sure if it's adequate. I also let you know that we've looked at the RAND study, and there are some big problems with the sample sizes and other things that came through the RAND study, and we dispute it. We have disputed it, and I don't think it's a really good gauge on whether or not Medicare is adequate. And comparing our rates to Medicare, I don't really know what it adds to the conversation. So I would say the answer is I don't know if 200% is or not. Why not 500%? Why not 1,000%? Which I mean, this is all new to us. We weren't even aware that amendment was coming. And then I think it would be kind of concerning to pass legislation without actually looking at what that means to the bottom line and how we operate. The other thing that I would also ask, if we're going to pass legislation, so in this bill, there's a lot of penalties tied to hospitals misperforming, underperforming, but there's nothing in here that says that the patients have to pay immediately. That we're still going to be in the same situation when we're still chasing our tails to try to collect from those that we have a process in place right now where we're able to take care of those patients. And I think until we come up with a better solution, it makes more sense to maybe study it and come up with a plan. But I just have real concerns with just saying this is the solution we should pass is sweeping legislation at this point.
Following up on Representative Hallinan's comment about the 200% of Medicare, and you were talking about administrative burden. I guess one thing, and you know, sometimes the person I asked doesn't know the answer, but if you were in business office and CFO, you probably have a rough idea anyway. But the bill doesn't address how to identify, and I'm kind of integrating the the proposed amendment into it, this discussion, the 200% Medicare, but it doesn't identify how to match up the patient you have with what the Medicare rate for that person would be. And so I'm thinking, and I'm supposing, suppose if you had a 25-year-old person who fell off his ATV and broke his hip, that would probably be a fairly uncomplicated thing. The patient wouldn't have any other comorbidities. Whereas if you had a 90-year-old who fell and broke their hip and also had pneumonia and maybe had a heart disease and, I mean, a lot of other things wrong with them, I would assume that Medicare would allow the hospital to have to charge more, or that Medicare would pay more for the second patient rather than for the first, with it being complicated versus uncomplicated. So, and maybe I'm wrong, things have kind of changed a bunch since I left the hospital side, but would it, to be able to decide how much to bill the uninsured patient, would you need to kind of figure out what the payment from Medicare on that kind of patient would be?
Madam Chairman, that's a really good question, and I think we've got some of our CFOs online that can answer this. But Medicare is a fixed rate for the episodic coverage of care, but based on different morbidities and different factors, there probably would be a different rate paid, if that makes any sense. And so your example is a good one. The other thing that stands out in my mind, it looks like to a certain degree, doctors' offices have been removed if we just focus on the big mean hospitals. But we employ 40% of our hospitals employ physicians, and they're billed through our hospitals. So are we going to exclude? I don't even understand administratively some of this, how we would do it. So if they're employed by the hospital, it's billed by the hospital. Is that then part of this bill, or is that carved out? You've got contract physicians that do radiology. Or you may have an anesthesiologist that could or could not be employed. There are more questions than answers as I look at this bill and try to peel the layers off the onion. I just see an increase in administrative burden, and I have so many questions that I don't have answers to. I don't even know exactly how to respond to this entire bill or parts of it.
More questions for Mr. Boley or Mr. Hannes? Representative Connolly.
Thank you, Madam Chair. Mr. Boley, when you started, or a little bit into your comments, you talked about Medicaid expansion. And so I want to start there. And I'm curious if you have any conjecture about how much the need for this kind of bill, using Representative Stiff's rationale, would go away if we simply expanded Medicaid.
Mr. Boley.
Madam Chairman, Representative Connolly, I think it's a great question, and I don't want to lose our conversation and go way into the weeds on Medicaid expansion, but we've seen an increased number of folks that would be eligible with the jobs that have been lost in our state, and with high paying jobs or paying jobs that had benefits. We do believe that there's a lot of potential, especially with some of the changes that are being proposed through the new plans that would help with an increase in federal match and other things. That we think that some of the working poor that we're talking about here that can't afford insurance and don't qualify, they don't qualify for any or can't afford the plans on the exchange. We think this could provide them coverage. And we believe that, with coverage, maybe they would take more responsibility and seek care in the proper places at the proper time, instead of immediately going to the emergency room for everything, because they have benefits. They could start seeing a primary care provider and other things, and working on chronic disease management and other things. So we think there is benefit to that. And I think it's worthy of a conversation. And I do think it could eliminate some of the concerns that were presented by Representative Stiff.
Representative Connolly, I'll just answer to that though before I'll have you follow up. But back in the 2015 timeframe when we had the original expansion, I was talking to Vicki Diamond, who at the time was CEO of Wyoming Medical Center in Casper. And I asked her if we expanded Medicaid, how much of the uncompensated care problem would go away. And her answer then, and I'm just saying that was her answer at that time in that issue, was about 30%. And I asked her, I was kind of amazed because I said, how come only 30%? And what she said was that so much of the uncompensated care actually came from people with insurance who couldn't pay their deductibles of $5,000. Because, and I don't know if Mr. Boley remembers the statistics, but some of this discussion is because actually, I don't remember, more than half of Americans don't even have $5,000 in the bank. So, if you go into the hospital and the bill, whether the bill is $200,000 or $100,000 or $20,000, half of America has like $500. So anyway, that's kind of a side thing. We've got to better make sure to stay focused on this. Go ahead, your follow-up now, sorry.
Yeah, thank you. And I asked that question in part because I don't want anyone going bankrupt because of healthcare costs. I mean, let's face it, somebody ends up in the hospital in an emergency situation and needs their gallbladder taken out or having a baby, even, that you don't want the next thing that they have to deal with is the reality that they could go bankrupt for paying medical bills. And so part of your argument in there was that you said at one point, we have a plan in place. And I'm just curious, it seems, who's the we? That not all hospitals operate in the same kind of way. That you're basically saying to us, we being all hospitals, and don't need this kind of bill to tell us what to do because we have it taken care of. And I'm curious about that. Who's the we? Who's assuring that these programs do exist and that people in need know about them? Because honestly, lots of people don't know to ask. You get your bill after you had emergency gallbladder surgery and you just sit back and say, oh my God, what am I going to do? Right? You don't know. So who's the we and who makes sure?
Mr. Boley.
Madam Chairman, Representative Conley, I absolutely agree with you. That's a great question and it's a great example. And I can only imagine being the person that receives the itemized bill in the mail. When I speak of we, the Wyoming hospitals, and there may be slight variations, but we have adopted as an association and as hospitals best practices. We've followed the guidance that's been delivered. This thing is huge, not only here, but nationally as far as collection practices are concerned. And I think it would be interesting, honestly, to gather data and find out how many people actually have gone bankrupt and have had liens and things put on their homes. I'll use an example from when I was in Kemmer. We had a couple of times when the collection agency got really aggressive and the constituent let our board know, and we actually ended up pulling that back at our expense because we didn't want to do that to our neighbors. And I think in a lot of our communities, that's what happens. It takes a long time to get there, but hospitals all across the state have been looking at this issue and they don't want to hurt people. Maybe an educational program to make sure that they know that financial aid is available and help is available. There are navigators across the state that help with getting people qualified for both insurance and Medicaid. We have people embedded in our hospitals that when a patient comes in, they'll go and meet with them and help them with the enrollment processes and things. It's a pretty robust system that each of our hospitals have adopted and are administering. And it may have slight variations, but I would let you know that almost universally across the state, each hospital is working diligently to make sure that these programs are in place for everyone.
Okay, more questions for Mr. Boley or Mr. Hennis? Representative Hallinan.
Thank you, Madam Chairman. Mr. Boley, I was a hospital board member for 9 years, so I can see your side of the argument. On the other hand, I know that the bills that are given out to people from, say, the emergency room, they're so high now for just, a urinary tract infection or something. They might have a bill for $300 or $400. I don't think a lot of people are aware of these efforts by hospitals, and Representative Conley brought that up, about the writing off of bills and so on. I don't know that this 200%, I think that's a pretty good estimate of what the bill, should be. 200% of the Medicare rate. I know that as a physician in my office, I would have been happy to get 200% of Medicare for anything I ever did. We never got, the Medicare rate would have been about $60. And if we'd have got 120, that'd have been very good. So I don't know that the percentage has been worked out to any degree of perfection to say that it would be 200% of the Medicare rate. Maybe it'd be 150 or maybe 250. But I think that's a pretty good approximation of what the maximum amount that people should be charged. So with that in mind, I know that you have a problem with the idea of setting that percentage without having a major study done, but I think that's a pretty good estimate. That's what I think. Thank you, Mr. Chairman.
Representative Stiver.
Yes, Madam Chairman, I have just one comment. My daughter just went to the emergency room, DKE, she's type 1 diabetic. And she just got her bill, not last night, a couple of nights ago, and brought it in. And it was, her out of pocket's $497. And right on the bill, it does say, contact us, make arrangements to make payments. It's all on that bill. So I just want to make that statement.
Representative Worf, did you have a question?
Madam Chairman, probably more of a statement. I can tell you, I've lived this. I mean, I had a child, uninsured, and was diagnosed with medulloblastoma. And fortunately for my family, there's a hospital to the west of us that deals primarily with children. And I can tell you they were fantastic. As far as I know, I met a lot of people. We did Catch a Dream, we did Make a Wish. And in that process, you meet lots of people that are going through very similar situations. And I can tell you, my family is the only one that I know that we were able to keep our house. And I can tell you, a lot of that had to do with my community. My community had multiple fundraisers for my family. And the hospital wrote a bunch of money off. But I can tell you, I personally, as an adult, have had worse experiences since then. And I hate to say it, it was with Wyoming Hospital and the collection agent that they had. And I can tell you, it was bad enough. I'm fortunate that I know a lot of people, and I had an attorney that represented me pro bono. The guy was actually the attorney was out of the state to our west, and he was doing things that were illegal. And one of the things it led to him losing his ability to practice in the state of Wyoming. Okay. And it's one of the things that I often wonder. I think back to when I was a kid, my mom worked at a clinic. The doctors had the ability to do whatever they wanted. They could waive fees. Everything didn't have to go through an insurance company. And as things have progressed, I've seen the medical situation has changed entirely. I actually at one time looked at being a doctor, but I'm glad I didn't go that direction. I just see more and more government involvement in our healthcare. And I think that's problematic. I don't think that's the solution. I think we're much better off. You mentioned a hospital, you worked in a community that I'm familiar with. And I think we're much better when you have that closeness and that tie to your community. I'm not sure what the fix is on this, but I can tell you there's obviously problems that we're trying to address. And I can tell you, like I said, I've seen it both ways. And I think this bill has some problems, but I'm probably going to vote for it, and I want you to know why. The reason why I will probably vote for this as amended, if it gets amended, is because I think this problem needs to be addressed. And I think if we don't do something, if we just let this bill die and we all walk out and we go back to our regular day-to-day activities, nothing is going to get resolved. And I don't think this is the fix. I want to make it very clear that I don't think it's a fix. But I don't think that the hospitals maybe know as much about how their collection agencies work, how offensive they can be. I've never tried to walk away from my bills. But I can tell you that there are some terrible people in this world, and they're not as kind and compassionate as some of the people that I've dealt with. But that isn't fair to castigate everybody as being like that. And so I do hope that you'll understand. I think the only way we're going to get these problems addressed is by doing the hard thing. And I can tell you, this isn't the fix. I don't believe it is, but I would encourage you to vote it out of the committee, just if nothing else, to have the body to look at this. Because I'm a firm believer in the more people that look at things, have common goals and objectives. And I think our common goal and objective in this body is to make things better for the state. That's the hospitals that are here. It's the people that live here. And I really think the only way that happens is if we identify those problems and work towards them. So I guess that's one thing I want you to understand. You know, I will vote for this in the committee. I won't vote for it on the floor. But I would encourage this body to at least let it out so that we can have the discussion and get people to think about what this fix is. I think it needs to be more than hospitals. I think we need to have the insurance companies. I liked it much better when doctors were in charge. And I feel like the insurance agencies basically dictate to the hospitals what you do. And that's just my perspective, what I've seen. And I would much rather try to get the monkey off everybody's back and try and deal with the issue. So with that, Madam
Yeah,
Chair.
let's make sure we leave time. I think there are also some people who have signed on online to come in. Representative Stivar and then Representative Romero Martinez.
Thank you, Madam Chairman. I believe this should be an interim topic.
Okay, and let's make sure while we have poor Mr. Foley and Mr. Hannis up here, we'll try to, I'm going to take some chairman's prerogative, but make sure we try to stick with questions. Representative Romero Martinez.
My question is, am I online? My first question, when referring to the systems that you have in place, and I've been through it, so I do appreciate you defending yourself and defending the good hospital associations for not having discriminatory practices. But my question is, when a person comes into the ER, do you make them fill out paperwork?
Representative Foley.
Madam Chairman, Representative Martinez, that's a great question. There's all kinds of paperwork that has to be filled out. The first thing we do is make sure the patient's stabilized and safe, and we, depending on what they're presenting with, but yeah, we do. And I think as has been testified, a lot of times there's information right there about either at that time or discharge about how to help with the bill.
Ballot for Representative Romero Martinez.
The reason I ask is because I had an experience here in the hospital of the city of Cheyenne where I went in and they did all that. So it makes sense to me that you made sure I would, or the hospital and the care workers at that time and the staff made sure that I was okay. But then they handed me all kinds of paperwork. And I remember a nurse one time saying, well, you need to fill that out. And I said, I don't need to fill out anything. In fact, I was on my cell phone. It was one that had a cord that you had to pull out because this is quite some time ago. And they just instructed me not to fill it out. One of my cousins, who's a good nurse from the military to the civilian side, he just reminded me, just remember the emergency room is there to take care of people who have a direct need. They can't turn you away. The nurse at that time said, we need to fill this out or you're not going to get care. So to the defense of the drafter of the bill, I think there are some discriminatory practices that do take place. Well, what ended up happening is I didn't fill that out. This is my personal experience. And I I did get care, and then they did walk me through the process of charity care, which is, I think they still might call it that. I think I agree with the good representative with the last name starting with W, that insurance companies have played a big role. And when I do a quick little Google search in healthcare costs, which is the most expensive healthcare system in the world, the United States is there at the top, followed by Germany and the United Arab Emirates. I also agree with the good representative that maybe we might need to look a little deeper into this. A good representative that's suggesting we need to dive deeper. But I also, I think I agree with everybody on the panel. Everybody brings a different point up. And so I think I would support this bill just because of the feeling you get when you're sitting there and you're not doing well and someone's almost makes you feel like you're being force fed some paperwork. Now, I didn't fill the paperwork out in the end, everything turned out good, but I think we have to have a deeper conversation about insurance companies. It wasn't too long ago before the ACA, that insurance was at the rate of approximately, or I had a quote for 90-10, and now you're looking at 80-20, 70-30. But what you haven't seen, if we have the highest hospital costs in the world, I guess my question is a second question would be, how much do doctors get paid in the United States versus the rest of the world? And you did ask us, and thank you for asking us to see some additional charts regarding another area of study. I also would like to maybe see that, because I think this is an area where I think we need to look at the entire picture. And I do hope that we can get some policies here in this legislative session that can make everybody happy. Thank you.
And I do see that Representative Ottman had her hand up, but committee, I just want to bring up here that Representative Romero Martinez brought up some really broad issues. And, to ask how much doctors get paid compared with the rest of the world is vastly outside the scope of this bill. I mean, and I'm not criticizing that, but one of the reasons that I went ahead and let this bill be scheduled is because I feel that as a committee, especially with a lot of new folks, we really need to learn a whole lot more. And so, personally, I'm going to vote against this bill because the floor also would need to really know a lot more. And I think it would be really easy to pass a bill under a vast level of ignorance. And when we had Representative Worf, who is no longer listening because Representative Stivar is talking to him, but one of the challenges with the discussion about government regulation is layering yet another layer of government regulation onto a system often doesn't make things better. And so I think back to the EMTALA law, which was extremely well-meaning, that people should not be turned away from the ER because they can't pay. Okay, who could disagree with that? But the consequence of that, from my perspective, is that people go to the ER and not necessarily for ER services. When I worked in the ER when I was in grad school, okay, so I obviously have opinions, but people would come in because their bunions hurt them. I remember this man, we would give him a bucket of warm water. We're like, we don't even want to sign you in. But people know that they can go to the ER and not be turned away. The consequence of that is that uncompensated care costs have soared. Was that the intention of the people who passed the bill? Certainly not, but that is an unintended consequence. So I think we need to be really careful about saying, here's a problem, here's a fix. We don't really know what the unintended consequence of that could be. And I had two questions. Sorry, Representative Ottman, Chairman's privilege, I'm on my little rant. Your question, CMS states that everybody has to be charged the same. So if in this bill, we set up a provision by which certain categories of people have to be charged differently, does CMS, what would they say to that? I guess, does that go against CMS's policy for national hospital behavior?
Madam Chairman, committee, that we're required to charge everyone the same under CMS for us to be able to be paid. For us to be able to keep our certification, our license to provide that care, we have to charge everyone the same. as far as what they actually end up paying, again, that's different, but everyone has to be charged the same amount of money.
So the only way you could be compliant with CMS would be to charge the uninsured people the same, but then secretly immediately say, but we'll collect this. I mean, you'd have to just sort of make a fake, here's your bill and here's what we'll actually take, right? I mean,
To a
guess
certain
that would be
degree, but
compliant.
yeah, Madam Chairman, to a certain degree, but I think we already kind of have a procedure in place.
Right.
And maybe we could do a better job of promoting it. But I think there's already procedures in place, and maybe that's something, I like the idea of either an interim study or working on it through our governor's task force, which we've been meeting now and we've got dozens of stakeholders.
And let me just, because
Yeah.
it's at 9:05, so I want to make sure we can get the people elsewhere. I just have one other thing to plug into this, for all of us to keep in mind as we're asking the questions. The issue that we're talking about is high healthcare costs. What this bill would address is the cost that an uninsured person ends up paying. But that doesn't change the expenses of the hospital. Guys, pay attention, please. When your chairman is ranting, you're supposed to pay attention. I just want you to remember that we're keeping track of the same thing here. If we're saying that such and such a person pays less, that will make their personal cost less. But this bill does not address the expenses of the hospital on nurses, on physical therapists, on oxygen, on tubes, whatever. So what we would be doing is saying, you pay less. It doesn't address the actual cost of the care to the system. Just make sure that we're not, it's a little bit like that voter ID thing yesterday. We were talking about identification, talking about registration. Make sure that we're focused on, what the issue is here. If we're trying to have poor people pay less, that doesn't solve the hospital's problem. Okay, Representative Ottman, thank you for patiently waiting for your little chairman rant. And then I think we do have some people online.
This should be quick, Madam Chairman and Mr. Boley. I was just wondering, you had said with the collection practices, what is the practice with someone, because this has been an experience, being asked to put everything on their credit card so that it could be paid versus you said that the hospitals do offer 0% financing. But that has been a first line thing is credit card. And the interest rate there's a lot of time are a lot.
Mr. Boley?
Thank you.
Madam Chairman, Representative Ottman, I think it's another great question. And I think all options for payment are explored. And so if the hospital could get you to pay on your credit card and then they didn't have to worry about setting up and administering a payment plan for 48 months or whatever, that would be their preference, obviously. And so I think they offer all kinds of different alternatives and options. I am actually aware of some facilities that have considered working with a bank to create something similar, a credit card where the bank would carry the note. I'm not aware of that being enacted, but they've considered all different avenues to try and collect. And I don't know in your case that you're talking about, but I would hope that because it's cash payment, maybe there was some concession made as far as a cash price or an upfront price, because there is value to collecting all at once as opposed to collecting over time.
Okay, committee, yes, Representative Stiver. No, it's okay. It's almost, it's 10 after 9, folks. We need to be, I know. Behave yourself. Okay, let's whether, I see her back there, but I'm sure she doesn't have a question for Mr. Boley. So let's let Mr. Boley and Mr. Hannes retreat unless you have a few last remarks here.
Just quickly, Madam Chairman, in response to Representative Worf, I understand that you feel like this needs to be looked at and needs to be worked on. I know the committee does, and you have our commitment, but I'm with the chairman. I've seen bad legislation passed because there wasn't enough information given. I would be hesitant and I'd be concerned that if we pass this out without actually looking at it, and we've addressed topic on top of topic that needs to be looked at. This has nothing to do with insurance companies. This has nothing to do with, doesn't really have anything to do with half of what we talked about, but it's all important stuff that feeds into how we take care of these patients. And you have our commitment. We're at the table now. We've been at the table, and we want to work collectively with this committee and with the body. But I am just really hesitant to say, let's pass it out and have the debate on the floor, because you cannot have a debate like this on the floor. You guys try. I've watched the House with their debates, but this is a lot of information. So I would ask that we move this forward, and happy to work on an interim, happy to work with the governor's task force to see if we can come up with solutions. And we appreciate your time. Thank you.
Madam Chair,
Representative
if I may, I got your attention. That's what I wanted. And really, as Representative Stivar suggested, an interim topic, I'm fine with that. So, I can go that direction as well, Madam Chair.
I am on the governor's healthcare task force. We've been meeting for about a year, I think, actually. And one of the main focuses is cost. When former Senate Chair Scott and I met with Governor Gordon within a month after he was sworn in. Was that 2 years ago now? And we asked him, we were in that mansion place where he was there temporarily, and we said, well, what is your interest? Do you have something specific in mind with healthcare costs? And his answer was, just fix it. So I think that was sort of the genesis of this lengthy, ongoing, and it will surely be easier if once we can start talking in person instead of the little rectangles. Okay, we'll let you guys escape. Ms. Chickish, I do see you back there. I want to just collect in people from online, while we seem to still have connection and they're there. I do not, so I see that we have registered Mary Lou Tate, Wendy Curran, and Maureen Caldwell. Let's just hear from them.
Madam Chair, I have 3 people with their hands up. Ms. Mary Lou Tate is the first. I will admit her.
Very good.
Good morning, Madam Chairman. My name is Mary Lou Tate. I'm the Chief Financial Officer at Campbell County Healthcare in Gillette, Wyoming.
Super, welcome. Please, go ahead.
Okay. I just wanted to talk a little bit about how this would affect Campbell County Health, particularly because that's where I'm employed and where I know the rules the best. Unlike private entities, hospitals already take care of a lot of patients, as you discussed, and we don't require payment upfront like independent facilities do, as you discussed. But what we're seeing here in Gillette, Wyoming is many private entities do not accept self-pay patients or Medicaid patients. And so they do end up in our ERs or in our physician offices, where we do have very many policies in place to help make it more affordable for them to come. By placing this rule, would it place additional burden on the hospitals? We already have to purchase different software systems to mimic payment policies to make sure that we're getting paid in full and that we're charging people appropriately. This would add another program that we'd have to purchase to make sure that we are complying with all the regulations in the bill. We personally give a discount at the time of service that's equal to our insurance discount. And then if someone pays their bill within 30 days of receiving their first bill, so usually the bills go out in 30 days if you're a true self-pay patient. So really, if you pay within 60 days, we give an additional discount, which is greater than the insurance companies allow with their contracts, because we do understand that the self-pay patient carries 100% of the cost and not a percentage as insured patients do. But if this bill is passed and we are now required to do other regulation things, we're going to have to cut that back, because we won't be able to afford to give every self-pay patient a full discount plus give these additional discounts. So we would have to evaluate the programs that we have in place today and whether or not we can afford to continue to offer all those programs. We offer financial assistance for families with up to 275% federal poverty levels. And we have a streamlined application process. It's only one page. If you show us that you're on food stamps, housing assistance, or your children have CHIP benefits, we write off 100% of your bill without having you fill out the application. We've opened this program up to not only uninsured patients, but also insured patients. Once again, if we have additional costs associated with writing off additional bills for patients, we might have to reevaluate what we offer in this program. Many times when we offer financial assistance, we have a tiered system ranging anywhere from 25% to 100% of the bill. Many times when we offer 75% discount, the patients do not pay their remaining 25%. Time and time again, we will work with the patient, we will write off a large percentage of their bill, and they do not pay it. And this bill does nothing to address the financial obligations of the patient to pay any portion of their healthcare costs to the hospital. We can't fire a patient, unlike a private entity. And so we still have to provide services even if the patient for years has not paid their bills. And we do that all the time. Once again, as talked about, we do offer many different options. One of which is the interest program or the long-term payment plans that Mr. Belay talked about. And the hospital does pay those interest rates. Once again, if we have to drop our costs and pay the interest rates, we might have to reevaluate which programs we offer to patients for affordability of payments, because we can't continue to offer free care and continue to carry all the other costs. This bill does not talk about what terms do the discounts apply. So it does talk about the insurance terms. The patient has the better of all the insurance rates plus the insurance terms. Well, in Wyoming, the state statutes say accounts have to be paid within 45 days for an insurance company. Well, what happens if a self-pay patient doesn't pay within 45 days? That is a term that the insurance companies have agreed to. So if a patient doesn't pay for 120 days, 180 days, do they still get the discount that's being proposed? Once again, we do a lot for our patients. We make sure that our patients are taken care of. We do not turn patients away, whether it be in the ER, whether it be in cancer care, whether it be in the primary care office. And once again, this just creates a lot of burden for us to track and trend and to make sure that we're complying with it. We currently have 4 financial assistance reps that patients can call if they have questions with their bill. On every bill we send out, there is language that if you can't afford your bill, please call. Financial assistance may be available to you. We post on our website not only our financial assistance application, but also the income levels so people can look at it and say whether or not they think they qualify, so that way they are informed before they call us. We do have applications at every entrance. They're available at every registration station. So if a patient indicates they are not able to afford their services that day, we ask that every registration person hands them an application and ask the patients to call us. Once again, we can't force the patients to call us, and many patients don't. I'm happy to answer any questions you might have.
Super. Any questions for Ms. Tate? Representative Ottman.
Madam Chairman, Ms. Tate, I really appreciate you coming with the experience of working right in this situation. You answered a lot of questions that I had. Thank you.
Thank you.
No other questions? Thank you very much.
I have a question.
Representative Hallinan.
Thank you, Madam Chairman. Ms. Tate, I understand that the hospital has many procedures for giving discounts for patients who can't pay. My question is, the twice Medicare rate, is that too low, or is that about right? What a patient would who is not insured, what they would be offered as a payment method. Thank you, Madam Chairman.
Ms. Tate.
Thank you, Madam. That's a convoluted question, because what most people don't realize is Medicare has a lot of programs that they pay the hospitals under. There's different rate schedules for whether it's a physician office, there's different rate schedules, whether it's outpatient, there's different payment options, whether it's an inpatient. If the patient has kidney disease and is on dialysis, there's a different payment method. And so it is not a straightforward answer. In total, our costs are about twice as much as the Medicare rates. But then Medicare pays us because we are a rural hospital. They understand our costs are much higher than, say, an urban hospital. There's a lot of different programs. And like Mr. Bully suggested, I would be more than happy to work with him and provide our information in a statewide study to look at whether or not 200 times Medicare is an appropriate amount in this case.
Okay, more questions for Ms. Tate? Thank you very much. Donna, I think it's Donna, the voice, the discombobulated LSO voice. How about you let in Ms. Curran?
Oh, I apologize, Madam Chair. Dr. Ryan Jackson had his hand up. Ms. Curran has not raised her hand to testify.
Okay, then let in Mr. Jackson. Or Dr. Jackson, that is.
Hello.
Welcome, Dr. Jackson. Nice to see you again.
I'm Dr. Ryan Jackson from the Wyoming Business Coalition on Health. And this is an interesting bill. I think that the motivation is good. We really need to address the high cost of healthcare in the state. I don't know that this really addresses it properly. And so I think there would be room to move this to the interim so that we could discuss this in detail and figure out what an appropriate way to handle this might be. So one example is 10 days ago, I had to get an MRI here in Casper, and it was $4,300. I have Blue Cross. It was $1,800 out of pocket. This is significantly higher than any of our neighboring states. And for similar equipment, and even when you compare it to hospitals with similar volumes. So something needs to be done about the high cost of healthcare in Wyoming. And I would love to be able to keep our patients in the state so that they don't lose time and money by going to our neighboring states for healthcare. But at the moment, I think that we're really facing a crisis, and many of the people just don't have the means to be able to stay in Wyoming to get their care. There was a study that you referred to by the Federal Reserve, and 56% of Americans do not have $5,000 to handle emergency expenses. And if you look at how many people are on healthcare plans with deductibles or out-of-pocket maxes well over $5,000, then we're going to be bankrupting a lot of people. And I'm glad that the hospitals are able to do some pro bono work, and I realize that they're taking a loss on a lot of patients, but we need to find a way where we can find a balance that helps the people of our state and keeps our hospitals going.
Okay. Questions for Dr. Jackson? Chair, Representative Romero Martinez.
My question for the good doctor is, what do you see as the top 3 factors relating to healthcare costs in Wyoming, just off the top of your head?
And Representative Romero Martinez, just make sure that it's tied in tightly to this bill. Otherwise, we're going to run out of time. But
Specifically
so Dr. Jackson,
related to the bill.
when you answer that, Dr. Jackson, if you could kind of aim it at, try to be concise on this.
Okay, Madam Chairman, it's a complicated issue, and there's many factors, but I think price transparency is a big thing, so that people can understand what they're going to face, what they're going to pay upfront. We have a lot of practitioners that are out of market while they're working for out of network while they're working for in-network hospitals. And that gets really frustrating for the patients because they don't assume that there's going to be an anesthesiologist or an ER doctor that they're going to see at their in-network hospital that is going to be out of network. And sometimes they don't find out until they get hit with the bill. So I think we need to know these costs up front. We need to know if there's staff at the hospital that is considered out of network. And I think if we can't figure that out reasonably, then we need to have a way for the hospitals to, if they're hiring, they're contracting with these out of network people, then maybe they need to take some of the financial responsibility for that.
Thank you, Dr. Jackson. Okay. He sort of illustrated my suggestion that this is a very broad, lengthy topic suitable for interim work. Representative Flitner, did you have a question?
Just a quick question, Madam Chairman. Thank you. And Doctor, you referenced, you cited information from a study. Is that the RAND study that you're referring to?
Dr. Jackson.
Madam Chairman, the study that I was referring to that said that 56% of the people do not have $5,000 to handle emergency expenses. That is from the Federal Reserve, and it was published in September of 2020.
The RAND study, Representative Flitner, was a different study, and it looked at how much hospitals were charging compared with how much Medicare was paying them for various things. And of course, it's wildly divergent all over the nation. That was a different study. Okay, any more questions for Dr. Jackson? Okay, thanks very much. Donna, is Ms. Cadwell in?
Yes, Madam Chair, I have 5 people with their hands up. Would you like me to admit them in the order that they raised their hand? Would you like me to admit Ms. Curran next?
Who do we have with their hands up?
Mr. Tony Gagliardi, Mr. Timothy Thornell, Mr. Nick Duchette, Ms. Maureen Cadwell, and Ms. Wendy Curran.
Okay. All right. You can just admit them in the order in which they had their hand up. And those 5 of you who are online, sorry, my list that I got this morning obviously grew. If you would just be aware that we have approximately 25 minutes before we need to adjourn and go upstairs. So please be concise. Thank you. Who do we have first? And if you could introduce yourself for the committee.
Thank you, Madam Chairman. My name is Tony Gagliardi, and I'm the Wyoming State Director for the National Federation of Independent Business, representing 2,700 small business owners in the state of Wyoming. Here today in opposition to House Bill 83. There's no argument that healthcare costs are expensive and getting more expensive by the hour. But this bill has some serious defects in it, and reminds me of that old saying, unfortunately, that the road to hell is paved with good intentions. While this bill is very well intended, as I said, it does have some serious problems. First of all, we believe that it creates it will create a large cost shift onto those carrying insurance if we start following what's outlined in the plan or in the bill. And second of all, we believe it provides encouragement for some to go uninsured if they know that they're going to be paying the same rate as an insured. And oftentimes, and I don't think it's been mentioned, that a patient has absolutely no clue what the real true cost of their care is, because it will depend often if you're insured or uninsured. And even if you're insured, depending on who your carrier is, you are going to have different costs. So it's an impossibility for anyone to know upfront how much their bill's going to be, unless it's a normal or what. For instance, if it's an MRI, you can find those costs. If it's an appendectomy, probably not. So we are more than happy to work with the sponsors. For over the last 25 years, healthcare and the affordability of healthcare has been one of the top 3 concerns of NFIB members, next to tax policy and regulatory issues. So we are more than happy to work with the sponsor through the interim. I believe businesses should be represented in any healthcare discussion like the one we're having. And with that, I'll be happy to answer any questions.
Great.
Thank you.
Questions for Mr. Gagliardi? Okay, thanks very much.
Thank you.
And who have we got next? Tim Thornell?
Correct. I'm admitting Mr. Thornell.
All right. Marilyn, don't let me forget you. Is that Sheila there behind the mask? Are you wanting to talk to, or are you just keeping? Okay, I'm not calling on you. I just wanted to make sure I knew how many people I had. Mr. Thornell, are you there yet?
I think I'm here.
Welcome, Mr. Thornell. I think this might be
Oh,
the first
thank
time
you.
you've been to Labor Committee. You're too busy working. I know you.
Thank you. Hi, my name is Tim Thornell, President and CEO of Cheyenne Regional Medical Center. I'm here today to speak in opposition of the bill. I'll make my comments succinct. We've had lots of good testimony already. I think we all appreciate that hospitals and healthcare is one of the most regulated industries in the United States. As such, as we've already, by some of my colleagues, elaborated on a lot of the processes that are already in place to provide discounts to self-pay patients. To give you examples, for our hospital here, for example, we offer a 30% discount or greater to all of our self-pay patients, and that really ends up being greater than our lowest insurance, private insurance company's rate. So in this instance, as the bill currently stands, using that methodology of the lowest commercial rate, it would actually disadvantage self-pay patients in that regard. And then as the introduction of the bill came forward, one of the main premises of this bill is to suggest that if we lower the rates, then our payments will increase. More people will be eligible and likely to pay their bills. And we certainly wish that were true. If it were true, we would already be doing it. Two, we would be supporting this bill if that were accurate. But by way of example for us, I can share with you of our self-pay dollars, this isn't people necessarily, but dollars, only 6% gets paid. That's 0.6% gets paid. We have also known through our actions that if we increase our discount, lower the rate self-pay patients have to pay, that number really doesn't change significantly. So at the end of the day, while this bill again has great intentions, and we in hospitals certainly appreciate the burden that healthcare bills pose to everyone, but particularly self-pay patients, and we too want to be part of the solution. This bill, we do not believe, will achieve the ultimate goal of making it more affordable for patients to actually pay it and change the behavior. What you're left with then is the administrative burden that this bill will have on hospitals. So again, I'll speak in opposition, saying that the bill, unfortunately, probably as written, won't achieve the goals as laudable as they are, but will leave hospitals with a more administrative burden than they already have, which in turn then just exacerbates the problem that we're trying to address here. Thank you very much, and I'll stand for any questions anyone may have.
Questions for Mr. Thornell? Oh, okay, thanks very much.
Thank you.
Madam Chair, I'll admit
I'm sorry, I
Mr.
didn't
Nick
remember the last
Doucette.
name.
Madam Chair, can you hear me?
I can hear you. What was your last name again?
Doucette.
Doucette?
Yes, ma'am.
Okay, very good. Introduce yourself, please, if you would, for the committee.
Absolutely. My name is Nick Doucette. I'm the administrator of Niobrara Community Hospital in Lusk. I think all of the main points that I would like to touch on really have already been touched on here. I really think the overarching goal of this bill is healthcare cost control. And I think to Madam Chair's point around unintended consequences of EMTALA, I think there's an unintended consequence of this as well, and it is that increasing of administrative burden in determining what our lowest contracted rates are, in determining what 200% of Medicare is, and in terms of just overall staff cost for us to comply with any such rules. I will just say that for our organization here, we do readily offer discounts for all of our uninsured patients. There is signage across our entire facility that says multiple financial assistance plans are available. For our sliding scales, up to 100% discount of charges All that's required is either a W-2 or a tax return. There's no significant registration process with that. We have federal requirements that we have to abide by that forces a lot of these programs into place, but we definitely go above and beyond that. And even on the statements that we send out, we automatically adjust down balances and also issue text on those statements that say, hey, more discounts may be available to you. Please reach out to us so we can set those up. So we certainly try very, very hard to treat our uninsured folks well. As Mr. Boley had pointed out, the working poor is a good portion of the population that we treat here, and we don't want to load undue bills on those folks. We already have a lot of those programs, and we think that the unintended consequence of this is just, unfortunately, more added administrative cost, and that only drives cost up. So that's all I've got, and I'll stand for questions.
Questions for Mr. Doucette? Okay, Mr. Doucette, thanks for all the care you're providing the folks up there in Niobrara County, and thanks for coming in.
Absolutely, appreciate it.
Okay, Donna, who do we have next? Wendy or Maureen?
Maureen Cadwell.
Okay.
Hi, can
Ms.
you hear me?
Cadwell. Yes, we can hear you, and
Okay.
we're sorry to hear you're not well, but please
Yeah.
introduce yourself for the committee.
I'm in my bubble at home, so yes. I'm Maureen Cadwell. I'm the CEO for Weston County Health Services in Newcastle. I won't repeat all of the other testimony that had already been given because it's all been said, but I would add something to it. Setting rates at 200% of Medicare is in essence setting our charges. I think Medicare would look back and say, if that's your charge for self-pay patients, that is potentially your charge for everybody. So that in essence would decrease our reimbursement all around the board. In addition to that, Medicare, as in a critical access hospital, has a cost report we do every year. And in that cost report, they take a look at our costs and compare it to what our charges were. And they will adjust it up and down depending on what our costs are. So if the rate is set at 200% of Medicare, but then we're adjusted a year plus after that potential fiscal year is done, how is that ever cost going to be then obtained from those self-pay patients that it was reduced to? So it gets very, very complicated basing it on cost reports. And that's really all I have to add. Any questions?
Questions for Ms. Cadwell? All right, thank you so much, and we hope you feel better.
Thank you.
And Donna, is Ms. Curran the last?
I can admit Ms. Curran, she currently does not have her hand up.
Oh, no, then we don't want her. Thanks for not raising your hand, Ms. Curran. Okay.
I don't see any other hands up.
Okay, very good. Let's turn to the room. Ms. Schickish, you had your hand up a while ago. Come on down. And committee, we'll see more of her too.
Would you turn your mic on, please?
Thank you. Can you hear me now? I am here today representing the Banner Health Hospitals in Wyoming. As all of you who do know me, over the last 10 years, I've represented Wyoming Medical Center. And on October 1st, the county commissioners sold the hospital to Banner Health. They are now owned by Banner Health, as is the hospital in Torrington, Wyoming, Community Hospital. The hospital in Platte County is a county memorial hospital managed by Banner. And then the hospital in Worland, Washakie Memorial, is also managed by Banner. So I'm really delighted to have this opportunity. I wanted to introduce myself in that capacity. And I'd be happy to discuss with you all about the sale of the assets from the county. It did create a medical foundation, which will be the largest medical foundation in the state, whose purpose is to look at healthcare issues and to study items as what we're discussing today. So I think that's another opportunity for all of us to be involved. I think this has been an excellent discussion, and I admire the sponsor of this bill for bringing this issue forward. I think and the chairman of the committee because it really is an issue for all of us. And I want to just say, I support what's been said by the hospitals before. Do not believe this is the solution. Specific to the financial assistance programs, I did want to say that most hospitals are evolving their programs. So with all the Banner Health hospitals, they have programs for the uninsured. They have programs for the underinsured, which are folks, as you had mentioned, Representative Wilson, who may have such a high deductible that they can't afford to pay it. And then they have programs also for the medically indigent, which might be somebody who, for instance, household expenses exceed 50% with regards to medical care. So I know healthcare costs are high, but hospitals are reaching out and attempting to address the issues with regard to costs. And in particular, Representative Ottman, I wanted to mention to you that Wyoming Medical Center, along with the other Banner Health hospitals, are in the process of implementing a credit card program with 0% fees. So that is going to go into effect soon at Wyoming Medical Center. And on March 1st, they did just implement this new financial management program. And I'd be happy, I probably will send all of you a copy of it. It's pretty complicated, but I think it would be helpful. I did want to mention one other thing too, is that all the Banner hospitals are members of the Wyoming Hospital Association and strong supporters and partners with them. And the hospital CEO in Torrington does serve on their board. So with that, I will take questions.
Questions for Ms. Chickage? No? Just rest in your elbow. Okay. No?
Thank you, Madam Chairman.
Our heads expand on the Labor Committee for sure. Thank you, Maryland. Ms. Bush?
Good morning, members of the committee. My name is Sheila Bush. I'm the Executive Director for the Wyoming Medical Society. We will be spending a lot of time together. And so I want to take a minute just to tell you who the Medical Society is. We're a statewide organization and we represent physicians and PAs. We have just under 1,000 members in total when you include all of our residents, retired physicians, active physicians, and our PAs. I too share the testimony of the person before me, thanking the sponsor of this bill and thanking all of you for spending the time with this. These are difficult issues. They're complicated. There is a lot to them, and they're very nuanced. So we do not support this bill. We don't think it is the solution, but we share the concern around cost in Wyoming. We agree that this is a problem. And so we are deeply committed to an effort of being solutions-based, identifying the problem, really seeing where the problem is. The bill in front of you today, as was mentioned before, seems to address one side of it without really getting to the core of the issue. The core of the issue is, why is cost so expensive in our state? And it's a very complex, and through our participation on the Governor's Task Force, we're also working on trying to identify what that is. We have a multitude of stakeholders peeling back that onion layer by layer. But it can't be fixed in one sort of one-off solution that doesn't offer a comprehensive wraparound understanding of the problem, and then a researched and evidence-based solution. And so we would urge you to hold off on this bill today and trust all of our commitment to really work on solutions with all of you to get where we need to go.
Questions for Ms. Bush? Okay, thanks very much. Okay, committee, it's 9:42. Representative Connolly.
Madam Chair, if I may, over the course of this conversation, I've been convinced that this is a really important topic, and that I've also become convinced that I want to know more, and that there are some issues with this bill. Because of that, I'd like us to not vote it up or down, and I'd like to move that we table it so that we can then put it on our interim list as a priority and have that more in-depth conversation following along with Representative Stivar.
Okay, does that
We
require
need
a second?
and then it's
Is there
not debatable.
Seconded by Stivar. All in favor of a move to table, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8. Any opposed?
I have,
We're having
I would like to say that asking that this be dealt with as an interim bill, I don't know that we can have the approval of the management council. So I think that might just be killing the bill and killing the idea of discussion.
Madam
So
Chair?
I'd be against tabling the bill. Thank you, Madam Chairman.
Representative Connolly.
But, Mr.
The
Chair-
vote was 8-1, but go
Yeah.
ahead, Representative Connolly.
And just Representative Hallinan, I am on management council and I will fight for it. And I also know that our chair will as well.
As a matter of fact, we had cost of healthcare. That was something that Senator Scott argued for strongly. I mean, he actually had a bill on studying costs several years ago. And the governor's office is very interested. I think we can be very sure that we will continue studying this topic. Committee, I also want to say, and we've got just a very short while to go back up. So the bill is tabled. One of the reasons why even though you could probably detect that I wasn't a big fan of the bill, but but I put it on the schedule nonetheless, because I feel like these issues are huge and really important. And especially as the committee is fairly new to healthcare, I wanted us to at least start getting an overview of some of the issues. So one of the things, and I happened to run into Senator Dockstader in the parking garage last night when I was talking to him about, it's so key that we're back here in person. One of the normally, and with the management council person to my left, normally during the interim, we have, assuming no COVID and all that sort of thing, 3 two-day meetings is what we've traditionally had. And during that time, we hear, potential bills, topics, whatever. I have felt that, and I haven't talked yet to Senator Baldwin, chair of the Senate committee, but I have felt that because healthcare is such it's a topic that has a lot of components. How does Medicaid work? How do people get on that? Medicare, what's the hospital cost structure? How do insurance companies pay? How do we produce providers, physicians, nurses, there's a lot of material. What I am intending to ask for is a 7th day just by Zoom, which I know we're really zoomed out, but it'll be cheaper that way. A 7th day that I would have at the beginning purely for education, and we can have presentations on a lot of topics. So what I would like you to do, assuming that, that people think that's a good idea, is as these bills come forward or as your reading comes forward, start tracking what topics you feel like you would like more information on for basically an all-day Zoom training meeting. I think that we could, you can't conceptually hear about the same topic for like 6 hours, but so we could have maybe 4 two-hour presentations, something like that. And we could still have things, obviously, as you go out through the summer, there's educational components. But if I could just ask the committee to really start thinking, what do I really need to know more about that I can't find out just by calling up, the doctor across the street or something like that. But so please do that. Thank you, committee. I think it's been a robust and really worthwhile discussion. I will chat with Representative Stith, and I'll see you all upstairs. The meeting is adjourned.
Thank you.